Hey folks, Scott Weingart here, and this is the MCrit Podcast. Today on the podcast, we're going to discuss some trauma. I've been thinking about this for a few weeks now. What had happened is I review all of the major trauma resuscitations by video. We actually record all our major trauma resuscitations, and then I watch them. And what I've realized is there's a real dearth of good trauma team leadership, and I don't blame the people involved. It happens whether the service leading the trauma is surgery or emergency medicine. It's a failing, I think, of the way we educate folks. And look, I bag on ATLS all the time. You folks know that. It's been an omnipresent feature on the show. And I should say, ATLS is a fantastic system for managing single doc trauma, trauma that shouldn't have gone to the place it went to, but it did. And there's one doc and maybe one or two nurses. It's perfect. But the problem is I think people are trying to adapt ATLS for actual major medical centers, level 1 and 2 trauma centers, and it doesn't work. And it leads to trauma team leaders that I think are just doing the wrong thing. And when I started thinking about, okay, well, what is the right thing? I realized that the educational package just isn't there. And trauma is kind of cool in that it is a bounded situation, by which I mean like medical resuscitation is virtually unlimited in the amount of possibilities and things you could do. But trauma is limited, first of all, by the real range of options on the menu for you. And since what we're really going to deal with today is trauma team leadership up until the time you first leave the room, it's a bounded amount of time as well. We're talking what it should be is about 20 minutes, 20 or 30 minutes at the most. So we could actually delineate all of the possible options. And then I'm like, well, let me think about this. What are all the possible options? And I started scribbling them down, and then I needed a cognitive system to really encompass them. And I started getting there. And then I wanted some peer review. So I said, yo, Chris Hicks, will you take a look at this? And then, as usual, Hicks puts in so much great input that I'm like, screw it, you're not a peer reviewer. Will you work on this with me? And so he's now my co-contributor, or my contributor, I guess, for this. And the way it's going to work is you're going to hear this podcast or vodcast today. And this is the primer of the, primer/explosion methodology that, we sometimes do on MCrit, which is I babble on about the initial range of things, and then I bring on a guest, and the two of us really talk about it on a much deeper, more granular level. So that's what we're going to do today. We're going to do the primer episode of what I am calling the labors of the trauma team leader. Now, why the labors? Because I was looking for a word that would encompass the things you could do. And I'm like, tasks, but it's not really tasks because some of it is cognitive, right? And so it's not a cognitive task, really. It's more like something you think about. So what word would encompass all of that? And I came up with labors, akin to the labors of Hercules or Heracles. And, that whole thing, beautiful mythology he had to accomplish. Well, these are the labors of the trauma team leader. Now, this is the blunt edition because we'll do penetrating at some point, and penetrating is a little bit different, a lot the same, but a little bit different. So the labors of the trauma team leader, blunt edition. All right, here's the gig. Here's the deal. Everything in blue are things that you, as the trauma team leader, do or think about. Everything in red are things that you assign to your team. Or, as I should really state it, you assign it to a sub-team. Because good trauma in real trauma centers is a team of teams, very much in the McChrystal vibe. And what that means is you are a conductor of the different parts of the orchestra, and you need to trust and allow those parts to do their job and check in with you, but not micromanage them. If you're micromanaging them, then the trauma is not running optimally. So that's what's in red. And then you'll see the last thing we have to do from a a baseline foundational sense to explain this is talk about the difference between solid and dotted lines. And solid lines are going to happen in every trauma, and dotted lines are going to happen in some traumas. Now, sometimes it's because the dotted lines will occur in sick traumas. Sometimes it's because the patient doesn't have the injury pattern to need that. And sometimes it's because the situation doesn't actually dictate using that box. So if they're solid, it's always going to happen. And if they're dotted, it's sometimes going to happen. Red is your sub-team assignments, and blue are the things you as a trauma team lead are going to do yourself. Now, you'll quickly note, if you're astute, that there's actually 2 trauma team leaders. This is very much akin to what's going on with the cardiac arrest treatments that I recommended, with a doc team leader, who's the trauma team leader on paper, and then a nurse team leader, who we will dub the podium nurse. But we'll get there. We'll explain all this. But that's the general layout, and we'll come back to this general layout at the end after we go through the individual cards. All right, so the trauma team leader, the overall summary. Now, this trauma team leader role could be filled by a trauma attending or an emergency attending, or a trauma team leader in Canada or Australia. It might be tentatively filled by a resident who's learning the role with a backup senior trauma team leader standing behind them and kind of advising them and there for advice. Either way, this should be the person who is heard for orders, for questions, and then the rest of the people in the room could speak, but the way they should speak is quite gently, almost in a whisper, to the trauma team leader, and that's how information is fed back to them. And then in the ideal world, the trauma team leader would repeat that information if it's something that the entire group mindset needs to hear. So for instance, the way I like to hear traumas run is the trauma team leader would say to someone, "Hey, do me a favor, listen to lung sounds." And they could say this in sotto voce, and then that person says, "Lung sounds are clear." And then the trauma team leader announces so that everyone in the room could hear, "All right, lung sounds are clear," if that information is pertinent to everyone. Okay, what are some of the overall roles of the trauma team leader? Well, they should perform a 0-point survey or a Z-point survey before the trauma even starts. And now, we're not going to go through this in depth. I'll link to it if you haven't seen it, but the 0-point survey is key. You know, Cliff Reed and a bunch of collaborators got together, created this, and this is what puts your assessment of the needs of the team, yourself, up front before the trauma even starts, and, role assignments, all that good stuff. All right, where do you stand? You stand on the foot of the bed. That's where you could command the whole room. That's where you're right next to the podium nurse, so you two could communicate. And if you're anywhere else, you've kind of lost control of the room. And we'll talk about how to handle that in a sec. You need to inspire a calm, quiet environment. Now, that doesn't mean you shouting out, everyone needs to shut up, and your entire role seems to be saying, "What's A? What's B? Do they have lung sounds?" That when I see people running traumas like that, it makes me want to slam my head against the wall. That's not the gig. It should be an enjoyable, fun environment in a well-run trauma. There may be occasional jokes being cracked. The information that is needed is gotten, but not in this regimented one person shouting out from the foot of the bed. Those people think they're in control, and they are laughable. And yet so often that's how I see traumas run, is just this shouting from the foot of the bed for the various pieces of a secondary survey that I don't even care about. If you have a trauma patient roll in and the patient's talking to everyone in the room and actually introduces themselves, there's no need to shout out what is A, for gosh sake. Okay, enough of that. So calm, quiet environment, closed loop communication. And if the loops are not being closed, then you actually have to ask for it. You have to say, when you ask for an order to the podium nurse, could you set up an A-line? And they don't say anything. You just have to say, please, could you do a read back of that? And that this inspires everyone in the room to start using closed loop communication. Recap, or as Chris likes to call it, sit reps consistently throughout the trauma. So every few minutes, hey, here's what I think we got so far. They're still hypotensive. Does anyone have any ideas of anything we're missing? What are we missing here? What should we be doing that we're not already doing? And those recaps, sit reps, questioning of the room will bring everyone to a safe environment where they could allow you to benefit from the entire brain of the team. All right, and then eyes on, eyes off. If you do have to leave the foot of the bed because something's going wrong with the chest tube and you're the only one in the room who could help out, you got to give someone else the team leader responsibility. And that might be the podium nurse, it might be one of your co-attendings or co-residents, but you got to say, I have to go eyes off. Molly, please take over watching 365-degree awareness of the patient. And then when you're back, you say, I'm back, eyes on. All right? So that's the trauma team leader role. Podium nurse. We call the podium nurse the nurse who traditionally is sitting there writing the trauma sheet, or during cardiac arrest, writing the cardiac arrest sheet. And they're usually at a table, so they're blocked off from getting involved physically with the actual parts of the trauma resuscitation. We call that a podium nurse. It was key to our nurse code leader situation in cardiac arrest. Well, same thing here in trauma. And what they should be doing is running a pre-brief. We'll talk about that. We'll provide that in future shows. They should be announcing the time every 5 minutes. We've been in the room for 5 minutes since the beginning. We've been in the room for 10, 15, 20, because otherwise you lose track of time. And they are aware of time because they're writing stuff down. Assign all the requested tasks. What does this mean? It means the trauma team leader says, I need an A-line set up. They don't say that to some random in the room. Even if they know the name of someone in the room, they don't choose to assign who's going to do the task. They tell the podium nurse, and then the podium nurse assigns all tasks. I need TXA. So the trauma team leader turns to the podium nurse and says, Molly, I need TXA. And that's it. They go back. Once the readback is done, Molly, as the podium nurse leader says, got it, TXA, 1 gram. And then you are done. And then he or she can do all of the assignments and actually make sure it's happening. Reestablish trauma team leader chain of command. What does this mean? The podium nurse is empowered to, first of all, if other people in the room are shouting out orders, promptly do not follow those orders, and have the trauma team leader or you remind the people in the room that all orders must filter through the trauma team leader. And if the trauma team leader disappears, they decide the best idea is for them to go work on a femoral line, then they need to ask for an assignment of a trauma team leader who is leading this trauma, or if need be, take over the role themselves. All right. Now, at our shop, the podium nurse is responsible for the finger stick and the tetanus. And if they don't do it, it's not going to get done because they are responsible for it. And therefore, it is outside my mind whether we're going to get a finger stick and a tetanus in the patient. So that's their role. And it's very dangerous when 99% of the time the role is taken over by one person, because we, in my shop, begin to forget to ask for tetanus or finger stick a lot of the time, because it's done all the time by our nursing staff. So it has to now be done all the time by our nursing staff. And then antibiotics if open fracture or a chest tube placement. And you could argue about antibiotics for chest tubes. We do it at our place, and so does Chris. If not, then you just cross it out. I'll give you the PDF for this in the show notes for this episode. All right, and then you'll see in tiny little letters the trauma sheet. And that's because that is the least important thing that they do. Now, the trauma registry people will tell you, no, that is by all means the most important thing, but I don't care. It is not important. It doesn't matter to this patient. It doesn't matter in the grand scheme of things, though they'll tell you differently. It allows retrospective registry studies to be done. And I want it done. I want it done right, but it is not the important thing. And you could yell at me, and I'm sure you will if you are, in the leadership role of a trauma service, but it is just not, in the grand scheme of things, all that important. Primary survey. It's a blue box. It's solid. It's always going to happen. And this is a misunderstood situation. It's a misunderstood set of tasks, because ATLS sends you astray, because they combine the entire management of the trauma with what we actually want from a primary survey when we have a big team. In ATLS, the primary survey is also your treatment plan, and you're not allowed to go to B until you finish A, you're not allowed to go to C until you finish B, and that's fine if you're a single doc. But for us, the primary survey becomes something very different, because all sorts of things are going to be happening simultaneously. So you're always going to run through the entire primary survey without stopping to see Did we manage this? So this is not a management strategy. The primary service purpose is to immediately identify life threats and then to get information that you will not acquire if it's not done immediately upon the arrival of the patient. So let's go through it. So now C precedes ABC, and that is stop major hemorrhage. If they're exsanguinating, then you do not do anything except ask a sub-team to start managing that major hemorrhage, if the patient's exsanguinating in front of you. So, and we'll talk about how to do that in just a little bit. Then A, are they protecting their airway? It doesn't mean you have to ask for airway management right now. It's simply a gestalt assessment of protecting the airway. Now, you may get this as a trauma team leader without any additional information. Sometimes you'll have to ask the person at the head of the bed, hey, is their airway okay? Like if you thought there were foreign bodies, broken teeth, a lot of blood, vomit, secretions, etc. But most of the time you can make this judgment yourself and you don't even have to ask for it because the patient's talking to you. All right, B is a gestalt understanding of their pulmonary status. And then you're going to get that from saturation, how they look respiratory-wise, and a quick glance at their chest. And then Chris and I disagree about whether it's even worth getting lung sounds. I still have someone listen for them, though I also do not put much truck in them. They're kind of garbage. All right, C, and you should be doing this yourself. Feel the leg, feel a radial pulse, and then do a quick assessment. It takes 2 seconds of the abdomen, and I actually squeeze in on the pelvis. And I do this myself as the trauma team leader, and it takes me 3 seconds. I do it as the patient's rolling in, and it gives me an enormous amount of information for those 3 seconds. Because if the patient's nice and warm, I feel very good about them. Sure, they may still have neurogenic shock, but for the most part, a warm trauma patient is a trauma patient doing okay. If, on the other hand, they're ice cold and I can't feel a radial pulse, we have problems coming. All right, D is your neurologic exam, disability. And this needs to happen now because if the patient winds up intubated, there's a chance you'll never get a neuro exam. And that really screws us up. And it's a 2-second neuro exam that you need. You need motor GCS. I honestly don't care about the rest of the GCS, and I could reconstruct it later on if I needed to, but it's just motor. That's all I care about is, does the patient follow commands? Do they react to painful stimuli? If they don't, and what is their reaction to the painful stimuli? What do their pupils look like? And can they move all 4 extremities? Super important to know now, because if they wind up paralyzed by our rock, then I'm not going to know to suspect neurogenic shock as one of the possibilities of the patient's hypotension. And then E, environmental, you keep them warm. All right, so you start thinking right now, if they're uncovered, to start covering them. The monitoring card. I need a saturation ASAP, and if I can't get a saturation, my first thought should be the patient has a perfusion deficit, most likely because of bleeding. So don't mess around a ton trying to, put the sat on 15 places. If a trauma patient can't generate a saturation waveform, the problem is they have no blood volume almost every time. Put on a manual BP cuff and then set the rep time at something low, like 2 or 3 minutes. Untitled CO2, not just for a patient who comes in already intubated from the field. Put on nasal cannula, Untitled CO2 on every sick trauma patient. It's such an enormous boon to have a perfusion monitor, which is what Untitled CO2 is. If the Untitled CO2 drops to 0, guess what? Your patient just lost their pulse. And if, their Untitled CO2 went from 30 to now 10, chances are the patient's not getting much blood back to the lungs anymore. So that should be a sign that badness is about to ensue. Sick patients get an art line. We'll talk about it. And then consider a temperature if there's anything environmental going on. And if it's a super sick patient, consider a temp Foley. All right? Because part of the lethal triad of trauma is a patient who is cold. It's going to beget coagulopathy and make everything worse. And you're not going to know unless you're monitoring temp. The access card. You're not going to be doing this. You're going to ask people to be doing this. Now, on, the routine traumas that aren't all that sick, then, 2 18-gauge IVs are fine. But if they're a sick patient, for me, I want one of these 3. I want a rapid infusion catheter. If you don't know what those are, we talk about them in other MCRIT episodes. An introducer, aka a Cordis in the United States, or for me, I love an HD catheter. That makes me really happy. Now I have 2 big bore lumens. The intrinsic design flaws of the introducers are not there, and these are fantastic. And then last ditch, obviously, is IO. Now for me, IO is not going to be lasting beyond me having to intubate a patient. So if I can't get IV access, IO is fine for me to give my RSI meds and maybe start blood transfusing through some pressure system. But then very soon on, this patient needs a introducer sheath or an HD catheter somewhere. All right, find the shock. This is what should be going through the mind of a trauma team leader. And, every time, this is the way to think about it. Not like we didn't put a card that says fast exam, because honestly, whether the fast exam happens in a lot of trauma patients, I don't care. It's not going to help me one way or another. If I have a patient who's relatively stable and I'm going to CT, I don't even want the fast exam. It's useless. So you don't think about it as a card that says fast exam. That's the wrong philosophy. This is how trauma team leading goes bad. Instead, you think about find the shock. So if the patient has signs of subtle shock or obvious shock, already hypotensive, then the find the shock card happens, and that's why it's a dotted line. And so some of the clues for this is a low end tidal CO2 or a revised assessment of bleeding and trauma score, which we'll put in the show notes what that actually consists of, but it's a better version of the ABC score. If that score is greater than equal to 2, that's a problem. You should be looking for shock. You remember the 5 sites of bleeding and you rule them out, which is, this, the chest, or 2 chests in this case, the intraperitoneal space, the retroperitoneal space, which also encompasses the pelvis, the thigh/femur fracture, and the street, right? So those are your 5 cavities or sources of hemorrhage. And you have to rule those out systematically. And ruling out the retroperitoneum is really tough. And so if you can't figure out anything else, then you assume retroperitoneal bleed or pelvic bleed. All right. Now it's going to help you here now to do a fast, right? And take out the various compartments that fast can access, like the intraperitoneal space, either hemithorax. If you can't get a definitive fast and the patient is not for sure going to the OR, then a diagnostic peritoneal aspirate can be super helpful. All right, chest and pelvis x-rays. In the old days, this took too long. You wouldn't get them into the room very quickly, and then you did, and you'd have to wait for them to be developed or actually brought back to the radiology department and then put in a machine, and then you could finally see them unpacked. Now I have x-ray comes to all our major traumas immediately. They're usually there before the patient. And then as soon as they shoot the x-ray, I see it on the screen. So now all of a sudden, chest and pelvic x-rays in some ways have obviated for me actually looking at fast ultrasound views of the lungs because I don't care anymore. I'm going to get an x-ray. Now, is fast more sensitive for pneumothorax? Hell yeah. Is x-ray better for me at actually seeing the extent of a tension pneumothorax that would actually cause hypotension? Yes. And so for me, if I can get a chest x-ray immediately, I don't care about the fast lung views. That's going to piss off the ultrasound people. So be it. And a pelvic x-ray could be super helpful as a ruling in of the retroperitoneal space as a source of trauma. All right. Think spine. Spine is a diagnosis of exclusion neurogenic shock. You could suspect it when you have a warm patient, a patient who is bradycardic in addition to their hypotension, though that could be a hemorrhagic patient. Don't get fooled. Hemorrhagic patients sometimes get bradycardic. And then medical causes. So, a single car accident where they ran into another car that was parked and the patient has the right, body habitus and risk factors for a heart attack. Sure. This might be traumatic, or it might be an MI. Again, a diagnosis of exclusion. After you take out all the possible trauma causes, after you take out sources of bleeding, then you can consider medical. All right, I've put the sedation and BP on one card because they work in tandem in a really critical trauma patient. Your goal map is, if you want to stick with a very safe number, 65, the trauma literature is pushing it lower, but 65 is a very good place. So you want to keep a map greater than that. But you don't just want to maintain your blood pressure goal, because if you do that by allowing a patient to do it with high catecholamine tone, or you actually do it yourself by, instead of giving blood products, giving vasopressors, you could have a patient with a good pressure but no flow whatsoever. And you'll know this because their extremities are ice cold. They don't have a palpable radial pulse. So I want both. I want to maintain a low pressure and have good flow, because what we know now is if you turn off flow to the organs, it actually begets the coagulopathy of trauma. That leaving a malperfused state makes the coagulopathy of trauma worse. So we need perfusion and keep the pressure low because we want to minimize wasted blood products the patient doesn't need, and we don't want to increase the chance of increasing bleeding or knocking off clots. So high flow, low pressure. The strategies to do that have been discussed in like 3 separate EMCrit podcasts. I'm not going to go through it now, but that's the deal. High flow, low pressure. Now, are vasopressors ever used in a trauma? Of course. Neurogenic shock? Yes, definitively. What about an old person with no catechol tone? You don't think they have neurogenic shock. They're moving their legs just fine, and yet their extremities are super warm as they're bleeding. For me, I like a balanced resuscitation in those patients. I'll give them some vasopressin and an norepi. And then a cirrhotic's another possibility where a balanced resuscitation comes in. And there's emerging literature that maybe every sick trauma patient would benefit from a dose of vasopressin at some level because they become immediately vasopressin deficient. More evidence needs to accumulate on that. Right now, all we have is that it saves blood products, but of course it saves blood products because it will raise the blood pressure and that keeps you from giving extra blood products. So it's not there yet. All right, and then the sedation side of it. One of the ways to get high flow, low pressure is to take away the patient's catechol surge with fentanyl, and it also treats their pain, so that's there. And we're not going to go through it any further than that. Ketamine is the sedation of choice for me when I have a patient that cannot tolerate anything else. And then sometimes you got to paralyze these patients to get the job done, to be able to get them to CAT scan and sit still. But make sure you sedated them if you're going to do that. One of the solid blue roles of the trauma team leader is situational control. You need to control the room. This is your job. And this is part of the 0-point survey, but you got to do it throughout the trauma. You got to make sure you're under control, you're in a good mental space, that your team is being protected and taken care of physically and psychologically. The patient, and this is when, if you have a patient who's, because of their hypoxemia and shock, is trying to slug people in the head, you got to take control of that. You can't leave that. And you got to control the room. Some of the tools for your control, dissociative ketamine for that patient that is obtunded. Maybe it's pharmaceutically aided that they are obtunded. Patient comes in on some meth or K2, then you got to take control. And I can't, exist in a trauma room for more than like 20 seconds without taking control. I would not try to fight a patient to get an IV line in it. So my threshold for dissociative ketamine is virtually nil. What we used to do at shock trauma is when the situation felt out of control, we tubed the patient and then we would just extubate him after if it just turned out to be alcohol. And then you got to manage the crowd. You got to get people the hell out of the room if they're causing disruption, and you got to keep your room calm, quiet, and controlled. All right, labs. Don't put much cognitive thought into this. The nurses usually do the normal stuff automatically. Make sure no matter how sick the patient is that you get 2 type and screen samples. It's going to change your blood resuscitation later on. We have point-of-care labs, and they're super helpful. Send a fibrinogen. This should just be part of your trauma lab panel, but fibrinogen is something that doesn't often get monitored. And then if you have them, the viscoelastic tests like TEG and ROTEM should start running now because they take a while to give you information. All right, temporary hemostasis. If they were having that exsanguinating hemorrhage, you got to manage it now. And, a bunch of this actually is more pertinent to the penetrating trauma, but, it still definitely applies for blunt, especially the scalp. So scalp, you're not going to try to do a meticulous wound closure. What you should do to direct your temporary hemostasis team is whip stitch the scalp, which just means take a big stitch. I don't care if it's absorbable or not. These stitches are coming out. Make one throw and tie it off, and then just do a baseball stitch running down the entire length of that scalp wound. Take enormous bites. Don't really worry about whether you're matching the wound edges. Just grab it tight. We'll take them to CT, we'll see what they actually have, and then we'll cut those stitches and we'll do a beautiful scalp wound closure. Figure of 8 for any major bleeders. Remember, Foley and holes. This is more pertinent for the penetrating, but anytime there's a hole in which the patient's exsanguinating out of, if you put a Foley balloon in there with a Foley filled with saline clamped off and inflate the balloon, all of a sudden that hole bleeding stops. Fingertip pressure on any exsanguinators, not a huge wad of 4x4s, which never actually stops the bleeding. Fingertip pressure with a gauze, 1 gauze or 2 underneath your finger, and then clotting aids and tourniquets. And we'll, again, talk about this more under penetrating. All right, there's a blood team. And what you're going to advise the blood team to do is the things on this list, because they should be handling it themselves for the most part. That's why your sub-team knows what they're doing. And so they should know how to check the blood, how to do level 1 or a Belmont transfusion. But these are some things that you keep in mind when you're advising the blood team. TXA, you should ask your podium nurse for it if it's less than 1 hour. You should ask your blood team to be using a commercial transfuser if they're just hanging the blood on a IV pole. They should know this, but you can remind them. Now, this is key because your blood team will forget this. No bungs or claves, those things that are lure connection to a syringe that are on all of our saline locks and IV sets now, those destroy flow. They destroy flow. So you as the trauma team leader must make sure that your commercial transfuser device is hooked directly up to an IV or up to an extension set that does not have a bung. You should be asking your blood team every now and then, how many units have we given? And you should be shooting for the 1-to-1-to-1. Consider concentrates to backfill, and that means prothrombin complex concentrate, especially if the patient is on anticoagulants like DOACs or warfarin, or if you're just behind on your FFP because you're at a center that doesn't have thawed plasma and therefore can't actually keep up with the number of red cells. One box of PCC is probably worth about 6 to 8 units of plasma, so you could easily backfill a plasma deficit. You could guide, once you have the results, by viscoelastic testing your TEG and ROTEM, and then consider supplementing with cryoprecipitate or fibrinogen concentrates if the patient's fibrinogen comes back low. All right, advanced airway. And again, these aren't in any particular order because as a trauma team leader, you're doing these all in tandem. These are all happening simultaneously. I could have put advanced airway 5 cards back and it would be the same exact thing because you are managing all of this in series, in parallel rather, not in series. That's the key to understand the difference between ATLS and this. All right, advanced airway, your sub-team should be handling this. You should not be micromanaging the airway. You should not, as a trauma team leader, be asking, what do you see? What do you see? If you're doing that, not only are you misunderstanding your role, you're screwing up the people actually managing. You're making their life harder cognitively. You're making them lose task concentration. Do not micromanage. But what you should see is you should see them have all the equipment they need laid out, not on the patient's chest, but on a table. That's what dump kit means. You should demand they do an airway checklist. If the patient's hemodynamically unstable, you should demand they either do delayed sequence intubation or an awake intubation and tell them, please don't paralyze this patient. Like if you see a traumatic pericardial tamponade on your echo, make sure you tell the airway sub-team, if they're going to manage the airway, you are not allowed to paralyze this patient or even put them on positive pressure ventilation. The patient must be allowed to continue to spontaneously breathe if they intubate. You need to be cognizant, and you could even say it out loud, 3 attempts at laryngoscopy, no more, please. And if you see them taking their 4th or 5th attempt, you got to stop them. And then you as the trauma team leader must either yourself, and this, because you might be the only person in the room who's really qualified to do this, or ask someone else to mentally prep for a cricothyrotomy. Art line. Now, I like art lines on any sick trauma patient, but the ones you absolutely require it on, to my mind, are the ones you can't get a blood pressure through a cuff. Those patients need an arterial line. It's dotted red. You're not going to be doing this yourself, but the things that you should be thinking about as trauma team leaders, ask the podium nurse for an A-line setup, and they'll assign someone. Make sure as the people are doing the A-line, you tell them this has to be in the common femoral artery. This will allow us to use this arterial line for things like Reboa. It'll allow the IR people to use it. It's a very different situation than if they go to the superficial femoral artery. So make sure to remind them. And then you tell them they have to use ultrasound. They must use ultrasound. There should be no blind sticks in the groin ever during a sick resuscitation. Ever. Must use ultrasound. Can't make that any more clear. If you're doing blind sticks and you're a trauma surgeon because you haven't learned to use ultrasound, there's no shame in that. Just let someone who knows how to use ultrasound do those lines. All right, chest decompression, aka finger thoracostomies. The time this needs to be done is either as a therapeutic maneuver when you already know they have a tension pneumothorax or big hemothorax, or as a diagnostic maneuver when the patients get so sick, peri-arrest, that you're not willing to take the time to wait for x-ray or ultrasound or trust those modalities because it has to happen in the next 20 seconds. And in those situations, it becomes a diagnostic maneuver. So if this is going to start getting done, you ask the podium nurse for 2 pleurovac setup, or if it's just one hemithorax, just one. But that allows this to start happening simultaneously to this. Now, not every time do they need a chest tube and a pleurovac or a drainage setup for a non-commercial imprimatur of that. But asking for it at this point is the right time to do it. You should ask the people, the sub-teams doing this on either one or both sides of the chest, that you want a fast finger slow plastic. And what this means is that they should do an immediate finger thoracotomy. So they get, in their gowns, hats, and gloves, which should take no time at all. They swipe the chest with a ChloraPrep stick, and then nice size scalpel incision. This is not the dainty aesthetic placements. This is, a good 3 centimeter, inch and a half size incision, and then pop in through with a Kelly, one shot, and then touch lung. And that's the fast part. That all should happen in less than 30 seconds. Fast. And then they can take all the time in the world to do the chest tube if the patient actually needs it. A lot of times, if nothing comes out of that chest, air or blood, I'm just going to cover that up with an occlusive dressing and we'll sew it up later after we get an x-ray. But if they want to place a chest tube, fine. But it has to be a fast finger, slow plastic. And then this is an eyes-off situation for the trauma team leader. Unless I have a co-attending supervising the finger thoracostomy, then I am going to go eyes off for a second. I'll tell the podium nurse, hey, watch the patient for a second. And I will put on sterile gloves and I will feel the lung on, whichever side or sides they've done a finger thoracostomy on myself, because it is too deadly to have them tell you, yeah, I'm in, I touched lung, and did anything come out? No. And you're like, okay, well, that side of the chest is done as the source of this patient's shock. And then it turns out they have a massive tension pneumo or hemothorax because no one actually got in. And so I touch lung myself, I go eyes off, it takes 15 seconds, and then I come back eyes on. That's key. All right, pelvis and femur. We used to say only bind open book pelvises. That's done. Any sick pelvic trauma or suspected pelvic trauma gets bound. So put on the binder, you'll get a post-binder x-ray at some point in the future. Tape the feet. If the feet externally rotate, if the legs externally rotate, you're not getting good binding. So tape the feet together. If it's a femur fracture, just bring it to length. We don't put on femur splints, traction splints in the trauma room. If they came with it, we'll usually leave it, but we don't pull it. We don't put them on ourselves. We pull it to length. And for either of those injuries, if you cannot control the exsanguination, then a zone 3 Reboa if you have that available. Brain preservation. This is when you change the resuscitative goals a little bit if you strongly suspect the patient has a traumatic brain injury. And you're going to adjust your BP goals. Now, we don't have great evidence for this. Rick Dunham might say, keep your BP goals the same. Keep it 65 on a map. But most of us are not brave enough to go to that place yet, so we'll adjust our map goals to 80. All right. PaCO2, if you are monitoring it, and you should, especially if you have point of care, try to keep them 35 to 40. If they have a blown pupil, signs of herniation, osmotics, like especially if they're hypotensive as well, then I prefer hypertonic saline, whether it be 30 mLs of 23.4 or 250 to 500 mLs of 3% or an amp of sodium bicarb. And then if they are herniating, then hyperventilation down to a PaCO2 of 30 is well suited to this at this moment. And then obviously maintain saturations. The correlation between hypotension or hypoxemia and bad outcomes is there. That was chestnut. We don't know if it's causative, but we do know it's correlated with badness. Okay. Secondary survey, which many trauma team leaders who are untrained spend a ton of time on. Not really important right now for the most part, except in terms of what not to do. This is a quick head-to-toe search for other injuries, just so they're in your head, just so you don't wind up having to take the patient back to scanner later on. So you rapidly search for injuries. I really put here, to help me remember it, extremity pulses. More pertinent in penetrating trauma, but worthwhile to do here. The patient has a bad fracture of their arm and you can't feel a radial pulse. That's a problem that we have to deal with sooner rather than later. Now, this is going to piss you off if you came from an ATLS world, but even though ATLS, I think, is finally on this page, if I remember my most recent iteration, but avoid the log roll. It does not help. We are scanning any sick trauma patient's spine. I don't care. In penetrating, it's a different world, but in blunt, I really don't care about a log roll. I don't care about feeling the spine. In fact, I think that's stupid and dangerous. And at this stage, I don't need a rectal exam. The rectal exam is going to do nothing for me in a blunt trauma patient at this stage. After CT scan, we could do a rectal exam. Here, it is totally unnecessary, and it requires you to move the patient, and that might screw up their pelvic trauma or spinal trauma situation, so just don't do it. This is going to piss off people. I don't care. All right, if you have it, Reboa is a card. It's dotted. It's not going to happen in anywhere near, all the traumas, obviously. It is the better choice in my mind for a blunt traumatic arrest than opening the chest. So definitely for a viable, not a patient with brain spewed about the scene or they've been in cardiac arrest in the field for a half hour. They're not going to make it, unfortunately. But, if the patient codes in front of you or very recently, then zone 1 Reboa is a lot more sensible than a thoracotomy, unless the patient has on your ultrasound something like a blunt trauma pericardial tamponade, in which case you have to open the chest, or horrible chest trauma, in which case a Reboa may make things worse. Okay, maybe for the peri-arrest patient, blunt trauma that's about to die, zone 1 Reboa, and then maybe even higher than maybe for bad pelvis that you can't get control of the bleeding with your transfusion strategy. All right, blunt resuscitative thoracotomy. If you're going to do it, and it probably should only be done for patients who code right in front of you, then go slow, right? Because it's a lot more dangerous for me doing a blunt trauma thoracotomy than a penetrating, because ribs are often fractured, and that makes it really unsafe. And the potential of you getting these patients back are a lot less once you've taken out the tension pneumothoraces, because you get it back a lot if you do an immediate thoracotomy on a patient that died just in front of you, and it turns out in the course of that you relieve a tension pneumothorax. I've had a bunch of patients survive from that. But if you extract the ones that have a tension pneumothorax or a pericardial tamponade, then this is really not going to augment survival all that much. I still think it's worthwhile doing if they code right in front of you, but go slow. If there was signs of a heart injury, if there was a pericardial effusion, then clamshell. Otherwise, I like a left anterior lateral thoracotomy, but I actually cut the skin all the way to the right nipple, because then if I need to extend across, I don't need to re-grab my scalpel. I could just come across the sternum with a Levski knife, and then I'm pretty much in. All right, and then always open the pericardium. You might think you could judge just by inspection whether or not there's effusion in there. No, the amount of fluid it takes to do a pericardial tamponade in a trauma is low. So I always open the pericardium, at least a snip, to see what comes out. And then sometimes cross-clamp. Why? Most people get cross-clamping wrong. You could probably do the same thing with pressure rather than a clamp. But if you know how to do it, this will augment your actual open chest CPR. Imaging decisions. We're going to do a whole podcast on this, so I'm not going to belabor it now. We're already super behind on time. But this is, pretty much at our stage of the game, every sick trauma patient gets a pan scan in blunt trauma, but these are the ones to add on to the pan scan. So I'll go through them really quick. If there's facial trauma, facial. If they're leaking CSF, then thin temporal cuts. If there's any potential for blunt cerebrovascular injury, like they have a bad head injury or a known because they came from another hospital, a known cervical fracture, or any of the other things we'll discuss in a blunt cerebrovascular podcast, and a CT angio of the neck. If you suspect, because they had a deceleration injury or a high speed impact or a fall from height, that there could be a traumatic aortic disruption, then potentially a CT angio of the chest. And if you have the technology, a gated CT angio of the chest is super helpful. Bad traumas at our place all get a delayed venous phase to help with splenic and kidney injury detection. Pelvic recon, if you already have an x-ray with a bad pelvis. CT cystogram, if when you put the Foley in, the patient has actual frank blood coming out, not microscopic hematuria, we don't care about that, but frank blood coming out of your Foley. CT extremities, if they had a disruption of that limb or you can't feel pulses on it. And then our orthopods have stopped injecting bad knee trauma. They do a CT non-con instead, which has been shown to be better than joint injection to see if there's joint violations. So there you go, CT non-con. Okay. When and where to go. This is one of the hardest decisions to make as a trauma team leader. When do you leave? Do you just stabilize them to the bare amount necessary and then rush them to the OR? Do you resuscitate in the bay to get them more stable? And this is a decision you make based on experience. And then your destination. They either go to CT scan, and we've really expanded patients who are willing to take the CT. Do they go to the OR, or do they go to interventional radiology? Or you might have a hybrid OR-IR, and then that makes that latter two categories easier to decide. if you've placed a zone 1 Reboa or you cross-clamped the aorta, you got 30 minutes to get that off. So make your decisions much more rapidly. And then it's worth performing a leave the room checklist run by the podium nurse. And we will put that in the show notes, and which the one Hicks uses, and then mine will be discussed in a later podcast. Wow. So wow. We got a lot of stuff we covered there. That's almost 50 minutes worth of stuff. Let's look back. So this green is the initial stages of what's going to be happening. You got your trauma team leader and your podium nurse there on the bottom of the screen, and you go through these initial things, and you do these all simultaneously. Like I said, they're all happening at once. And then these are your secondary items. And this whole thing is very quick. This is just, this could happen in the first minute. And then you choose through these dotted modalities, depending on what's going on in the patient. Your Reboa and your resuscitated thoracotomy are kind of like a end stage of your resuscitation pattern. And then when you're ready to go is imaging decisions and when and where to go. All right. I'm sure there are things I've missed. I'm sure there are things that you think I missed, but I actually thought through and didn't want to put on here. Like, for instance, a rug, a retrograde urethrogram, because I don't think they need to be done before you leave the room. You could just leave them without a Foley and do them later. So if you think I've missed something, please comment. Let me know. Let me know if you think this entire thing is dumb, because there's no point in me doing the penetrating version of this with Chris if this entire thing, you're like, this is stupid. We didn't need this. This was just a waste of almost an hour of my time, Weingart. So let me know what your thoughts are on this. This cognitively, to me, feels right. This feels like something I never saw out there before. The menu, the complete menu of labors of a trauma team leader. So the bounded reality of your role is actually there in front of you now, and all you have to do is pick and choose. Now, please, I'm not advocating you hold this in front of you during a trauma resuscitation. That's not the point. The point is for you to now have the ability to mentally simulate all the available tasks. And, maybe it is worthwhile in a simulation, like a real simulation, like an in situ sim or a sim room sim, to have this sheet in front of you and actually look at these options as you're given a case of a sick trauma patient, because it's going to allow you to really see this is the bounded reality. These are the items that I could or must do. All right. Whew. I have no voice left. I can't wait to hear what you think. And then, like I said, so Hicks, in like the next week or two, we're going to do the second podcast where we're going to address his thoughts on a lot of this. I'm going to hit him with some ideas. And if you've asked questions from this initial foray, then I will, answer them with Chris. And we'll see what we could do with that. And then, like I said, we'll develop the penetrating one if the feedback on this is good. Whew. Okay. This has been Scott Weingart from the MCRIT podcast saying bye-bye. All physician CME for the MCRIT podcast is provided by EB Medicine. EB Medicine is the purveyors of the best evidence-based medicine publications out there, and you can find them at ebmedicine.net/MCRIT.